thank you so much. Thank you so much for agreeing to come and speak to us today and share your experience with our students. Cormac Russell is a social explorer, an author and sought after speaker. He is the Managing Director of Nurture Development and a faculty member of the Asset-Based Community Development Institute at DePaul University in Chicago. Cormac's work has demonstrated real impact globally, where he has worked with and trained communities, agencies, NGOs and governments in community-based development approaches aimed at increasing health and well-being. His work recognises that through collectivism and mobilisation, people and their communities can extend their capacity to increase their own health and well-being and the health and well-being of the communities that they live in. Following Cormac's keynote speech, there will be time for questions. You can raise your hand and ask a question. If that's not possible, then you can use the chat function, and we'll be keeping an eye on that. So Cormac, it's over to you.
That's fantastic, Jane. Thank you. And great to be with you all. Now, one of the things that's often helpful to do with online conversations is act like we like each other. And one of the ways practically of doing that is to turn on your camera if you can at all. So let's try and create a sense of community and a sense of connectedness. It's really important, particularly in these times. And great to see so many warm faces. Great to be with you today. I was in Barcelona yesterday. We had a wonderful conversation with partners across the public sector and third sector. And indeed, we were graced by the presence of some very senior political folks from Spanish government and from the Catalonian region as well, all very passionate about the idea that well-being is something that's created ground up, that you can't just deliver it as a service. So I think that idea is becoming very in vogue, the understanding of health, not as a medical, but as a social and a political good. That's what I'll very much be talking about. That's my tradition. And so I started my own career as a clinical psychologist and have been in recovery now for about 30 years. But I discovered community along the way, and that's what I'm going to share with you. So I thought what would be fun to do today is to tell you a little bit about the new book that myself and John McKnight co-authored, which is coming out at the end of September, the 27th of September, actually. And the reason I wanted to share the book with you is because I think it gives a really straightforward way of thinking about population health from the ground up. So a very solid, practical way of understanding what we mean by that, how you do it on Monday morning. And I thought that would be a fun thing to spend our time doing this morning. So let me use my slides to keep me honest, as they say, and keep me focused. There we go. Do the techie piece. Can you all see that? Yeah. Okay. This is a bit discolored. This is the cover of the book, The Connected Community. And I like the idea of calling the book The Connected Community because, in essence, what we're trying to articulate, certainly at the ABCD Institute, is that one of the most primary or simple units of democracy is the neighborhood. So thinking about the neighborhood as a primary unit of change, and indeed as a primary unit of health. And I think while this is a simple idea, it's quite a radical idea as well, because what it does is it takes us beyond thinking about the individual and the body as the unit of health, or indeed the professional or the institution as the health provider solely. And what it opens up is the possibility that actually places where all of these things can come together. So that's the theory. And Parker Palmer, and I think some of our colleagues who are with us from North America may be familiar with Parker's work. Indeed, if you're ever looking for a book to reground you vocationally, this is particularly important for students who are on the call. In 10, 15 years' time, when you feel yourself being sucked into the bureaucracy of the institution, and you need some kind of antidote to that, to bring you back to why vocationally you're doing this work, read Parker Palmer, any of his stuff, and it'll reground you. So Parker very kindly agreed to write the foreword of our book. And I love what he says here, because I think personally it's so true. He says that our disconnection from people and place diminishes our quality of life. It's one of the root causes of a range of personal and political pathologies in today's industrialized society. And that certainly rings true for me. So in terms of thinking about the framing of asset-based community development, and that's the world I come from. So when I think about working with communities and I think about population health, I think about how do we do this in a community or an asset-centered way of working. That means starting with what's strong within communities and locally within communities rather than what's wrong. So the framing of today's presentation is pretty straightforward. And I thought maybe I'd share each of the three phases, but stop after each one and give you the opportunity to absorb, because it's a lot to take in, even though I'll be sharing stories. I think it's nice to make this participative and interactive. And I'm genuinely interested to be a guest in your learning rather than to be the sage on the stage. Because I think part of the challenge here is we have too many experts and not enough hosts. And the world needs more hosts, not more heroes. So in any case, the three phases are discover, connect, and mobilize. And what I'd like to do is take you through each and stop and pause and hear your wisdom as we journey. So let's start with the first. I'll say a few words on that. Firstly, I think when we're thinking about community without community, we're already in a problem. It's really striking to me how often people in health and allied health fields are talking to other professionals about communities, but communities aren't in the conversation. And one of the most practical things I think we can do as people who have a vocation to support people to be healthy is I think we can actually just go and be with communities rather than talking about them. So in a sense, that's what we mean by discovery. But there's lots of layers and filters that get in the way of actually just being with community and really deeply listening and discovering what matters to them. And some of those layers are our own institutions and our own professionalism. So our specialisms are like a filter, which can either illuminate the space we're looking at or make it hard to see clearly. And what I want to argue is that in many respects, many of the health professions, I think, have a challenge. And the challenge is that the lens through which they look at communities is not always very illuminating. And sometimes all they're seeing is pathologies, sickness, deficiency, deficits, and they're not actually seeing health creating capacities. What I want to argue for, or at least commend to you, is that there's another way of seeing communities. The map is not the territory. And the other way is to actually get into the territory. And this is something historically that public health nurses, district nurses, and sometimes for many, many years, general practitioners did. They were rooted in local places. And around about the 80s, a lot of our professions became syndicalized. And so we have this great dilemma, I think, that many of the public think their health is in your hands. And this is a really problematic story because it's likely to cause burnout for professionals and it's likely to disappoint the public. And I think this is a big reason why we saw so much vaccine hesitancy during COVID. It was a matter of trust. And in a sense, the vaccine was just symbolic. It really could have been anything. But in a world where everything moves at the speed of trust, I think we have a lot more work to do in building the trust of communities, particularly marginalized communities, Black and brown communities, and communities where there's a real sense that they haven't been well served by institutions. And indeed, a growing recognition that institutions are carrying the burden of institutional racism and not always checking their privilege. So that's the not so good part of it. The more hopeful story I think I can share with you is if you imagine conceptually everything I've just said for the last few minutes as being almost like you're in a nighttime flight, a nighttime airplane, okay? And you look out over whatever city you serve. So you look down on the city. The current narrative around health and social care is that the only power sources in that city, the only places with the lights on, are institutions, our schools, our hospitals, our prisons. That's where the power is. They've got the power to produce our health. They've got the power to produce justice. They've got the power to produce well-being. And all of the dark matter in our cities is represented by neighborhoods. All they have the power to do is to consume. They are the sum of their needs and their deficits. Now, what I'm arguing for is a better story than that one. Because if that's the dominant story, if that's how citizens see their health, and if that's how professionals see their health, and that's how policy makers and politicians see health, we're in trouble. And so I think a big part of what people like you and me can do is we can curate better stories. And we can disrupt the stories that are life limiting and are limiting in terms of well-being and resourcefulness as well. And so a lot of my presentation for the next little while is proposing an alternative story, a story that says actually neighborhoods are a power source. And if we could discover, connect, and mobilize those assets, those building blocks of health, then we could supplement that with good services. And we'll talk a little bit more about that, but that means instead of starting from the institution out, we're starting from the community up. And it's exciting because I think that that says, from a current reality where citizens are waiting for the cavalry to ride over the hill to save the day, or are disappointed and don't believe they can trust that the citizens would be the cavalry. I think we're saying, well, actually, there's so much more to be gained by thinking about health as I describe it in this slide. So in essence, this is a very simplistic way of describing my vision for health in the next number of years and decades. I think health is about placing the person at the center of everything we do, but not as a unit of pathology, rather as a unit of gift. So seeing people as gifts, as having a contribution to make, not just to their own personal health, but also to the health and the well-being of their community. It's very interesting to me how many people will not actually do things to improve their own personal health, but will do things to improve the health of their family and community. And in the process of doing that, will also enhance their own health and well-being. So it's interesting, in Wales, they often ask people to consider what matters to you. Well, in my work, I have found that if you extend that question a little bit and really listen carefully and find out what matters to the individual that they could contribute to the well-being of their community, you open up all kinds of new possibilities. So while I'm putting the person at the center, I'm not putting them at the center as a client or as a patient. I'm putting them at the center as a citizen. And I think we really do need to center citizenship in the health narrative. Now, I don't mean citizen in the sense of somebody. I have a rather unusual lifestyle where I carry my passport everywhere I go, except to bed, obviously. But when I'm, it's in my pocket at all times, essentially. So I don't mean it in terms of paperwork or documentation. I mean it in terms of this idea of being a contributor to the well-being of others, as well as a consumer for your own well-being. That's really, so journeying from being a client to being a citizen. Outside the little stick person, you see circles. And what I'm trying to represent there is associations. It's clubs, it's groups, it's associational networks that I think are hugely important. Most of those dog walking groups, book reading clubs, they do not have constitutions. They do not have chairpersons. They are informal. They're below the radar health creators. Now, any health practitioner that's really interested in population health will recognize that this is the engine room of people power change, not the hospital. If epidemiology is correct, and if the social determinants of health are correct, and it's pretty clear that they are, then associational life is a critical driver for population health. And it's very interesting that 90% of most of the money that's put into healthcare doesn't go into building communities. It goes into building institutions, programs, services, and pharmacology. And yet 85% of what determines health and well-being is related to community assets. You know, my personal agency, my economic well-being, my environmental circumstances, and my associational life. Now, for those who are not familiar with the language of association, I'll talk more about it. But in essence, what I'm saying is it's much like, you know, you have a flock of birds, you have an association of citizens. And one of the reasons I think so many of our cities are so unwell and are not reaching the sustainability goals is because we've got so disassociated from people and place. And that is really very harmful for health and well-being, understood in that dynamic sense of the social determinants of health. So I think a big part of our work is to think like veterinarians. Like a vet would never just deal with a sick animal. They would be curious about the herd. They would be curious about the community. And in much the same way, we need to think much more dynamically, particularly as we move into a pandemic conscious future. And as we recognize, I was in Barcelona yesterday, and you know, it really struck me, the heat waves are starting earlier and earlier. So there's a heat wave now. Typically, that intensity would not be something I would have experienced until July, August. It's there now, and you know, people are fleeing to the coast. But there are many people over the age of 65 living in poor, substandard urban housing, often Black and brown, marginalized communities, often women, often lonely, who are, you know, for them, heat waves are a matter of life and death. And interestingly, yesterday I shared the fact that in 2003, 70,000 people perished directly as a result of the heat wave that summer. And hardly anybody knows this in public health. It's really striking to me. So I often say to people, who, you know, which disaster claimed more lives, Hurricane Katrina or the heat wave of 2003, August 2003. Nearly everybody says Hurricane Katrina. In fact, Hurricane Katrina claimed 1,836 lives, all tragic loss. But that heat wave claimed 70,000. And interestingly, I suppose, what we might consider a country with preeminent health care, being France, and the city of Paris, again, being preeminent, I think, that they were the hotspots, if you forgive that turn of phrase. 15,000 people died in France that year, directly as a result of that heat wave, and 5,000 of those were in Paris. So why was that? Was that a failure of the healthcare system? No. In fact, that goes back to what Parker Palmer was talking about. It's a failure to cohese the social fabric. And this is such an important thing for us to understand, that healthcare isn't a product that's consumed. It's a condition of life that's co-created. So recognizing that communities are at the heart of that, excuse me, I jumped there. Now, before we break to have a quick conversation with each other, one thing I want to emphasize, you'll see triangles throughout the slide here: not-for-profit, for-profit, governmental, non-governmental. What I'm trying to illustrate to you here is that health properly understood sees institutions supplementing the community assets that I've been describing, not replacing them, demeaning them, undermining them, or overwhelming them by claiming we're the experts and we're the ones that know. Right? So what I want to try to do now is just stop for a few moments and say, I presented some thinking to you about a shift from delivering services to discovering community assets and then supplementing those assets with good services. So I want to stop. We haven't a huge amount of time, but I think we have a couple of minutes to begin to grapple with and engage with what dilemmas and what possibilities does that shift from delivery to discovery open up for you in your mind. I don't suppose we have time to do a breakout, but we're a small enough number, so perhaps we could just do a quick micro Q&A and see what's on people's minds, and then I'll go on to connect as the next topic. So what strikes you about what you've heard me say so far?
Thank you for the interesting talk so far. I'm sure we can all agree that we appreciate the thoughts that have been put forward to us. So I just finished my last year of medical school, and so I'm looking to become a hospital doctor on different rotations, where I'm going to focus on different specialties for 4 months at a time. And I guess I'm thinking about how this will translate into the work that I'm looking to do now, because of course I'll be in the hospital focusing on patients. Ward rounds will consist of, say, 20 max patients, and I don't really see where the room will be to think about a wider community in terms of specialties and individual patients. So there is a focus on putting the patient at the center, but putting the patient as a citizen in the center seems quite difficult.
Yes, I agree with you. So much of the money in any city goes into hospitalizing people. And I think most people would accept that that isn't always the best solution, and in fact could be counterproductive for the well-being of many people if they stay too long in hospital. So I think part of the challenge is to create step-down care and community alternatives to hospitalization. In the province of Alberta, 50% of the tax take goes in to acute care and hospitalization, and hardly any goes into supporting people to return back to their communities and live well in their homes with good localized primary care. So I think you've defined the problem, the dilemma. And the dilemma is we are primarily back in that airplane again, only seeing the hospital as the solution. And, you know, the fire hydrant of need is coming at us at such a pace. People like you are at the front line of that. And it becomes very hard for you to imagine how you might do anything over and above what you're doing. You've got to meet the demand as it faces you. But what I hope is that maybe somewhere along the line, you may be actually in a policy position where you can begin to start thinking about the hospital as a neighbor in the neighborhood that you serve, and beginning to ask questions like the police force are asking in Milwaukee. Why is it the same 15 neighborhoods produce the alumni of the prison in the city, prisons in the city? And it's the exact same 15 neighborhoods that produce the alumni of the hospitals. And it's the exact same 15 neighborhoods that can't actually take people home, so end up pushing many of their neighbors into congregated care settings or extended hospitalization, which is counterproductive to their health, in fact. And I hope that perhaps you would be able to influence those kinds of questions, like we've seen in Edmonton, where by investing upstream, you know, before people fall into the river, and really building the cohesion of neighborhoods, we're seeing a reduction in the flow downstream of demand that hits you on the hospital ward when you do your rounds. So I think we've got to get further upstream. It is too late when you're doing your rounds. That's not the point of intervention. The point of intervention is before people fall in the river. And you know, I would say that's not just preventative thinking. I would also say we need to go further. We need to go past prevention into creation. What is it that communities can do? So you think about taking, after George Floyd was murdered by police, right? And it was undeniable that structural racism is a feature of how public services work in the United States. There was a cry and a demand for justice. And part of that came in the shape of saying, let's defund the police. So Black Lives Matters spoke about that, and I completely understood that. But in our conversations, one of the things that I asked for some consideration around was, well, what will we do with the money then? And the answer in many cases was give it to mental health institutions. And in my mind, I thought that was very wrong-headed, because essentially we were moving from, a form of one violence to another in some instances. And what I've asked for is some thinking about what are the community alternatives to institutional interventions. And one of them is employing community organizers in the neighborhoods, from the neighborhoods, to really begin to address issues of social cohesion. So I don't know if that answers your question, but hopefully it broadens out the scope of the question at least.
Yes, definitely. Thank you.
Thank you, Josephine. Let's hear from one or two others before we go on to talking about connection. Anybody else like to contribute?
I think something that I was thinking about was how, like, what the barriers are to doing joining a community group. And something that came up for me, being like a student for, the past 10 years or whatever, is like how little time we have, or like the little time that we do have, we're forced to spend, like, not always forced to spend, but we do spend a lot of it sort of online, like on laptops or on our phones. And I think one of the big pushes that we'll need is to show people like the benefits of being like outside and being with other people again, which is quite difficult in a post-lockdown world where so much is happening online.
I totally agree. And one of the things that I like to do as an indulgence personally to myself is not to use the word offline anymore. So I talk about online and on land, because I think it just re-embodies us. And, much of your work will be so central to the sense of touch. So as people become more, particularly traumatized people become more embodied within their own sense of themselves, within their associational life, within place, wellness flows from that. So I think you're absolutely right. It's critical that we support people to re-engage and reconnect sensorially, physically, with other people in place. And that does demand something beyond just the online experience, although that's been very helpful too. One of the things I think is really useful to remember here is that a lot of people, when it's almost like a duck call, you have different whistles that different species of ducks respond to. I'm really struck by how we invite people into the commons, how we invite people into the civic square. It's sometimes very intimidating. It's like volunteer or, get involved publicly or, join a group. And if you're not feeling very confident in yourself, or like so many of us, you've kind of gotten to a point where you become socialized to the online experience, that can be really scary. So I think a big part of what I would start with is not so much encouraging people to join or be involved in activities. I would start by discovering what people care about enough to act upon themselves, and then find spaces and paces at which, at the speed of trust, really, people can be invited into that. We're journeying with 100 men at the moment who are coming out of prisons in Wales and returning to communities in Cardiff. And one of the things that an early win for us is we've convinced everybody to refer to the men as community returners rather than ex-prisoners. And it's so much more helpful for a community to think about people as community returners. We have a lot of people who spend their lives in waiting rooms and on queues and online, who are not connected for various reasons. So part of the challenge is supporting them to recognize they are enough, that they have gifts, that they have contributions. I don't think we're going to get a lot of people wanting to join groups on the basis of saying, oh, you've got a pathology, you've got a certain form of diabetes. Well, there's that form of diabetes is dealt with over there with that group. Why don't you join them? That will make you well. Well, to an extent, there may be some argument around that in terms of peer group support, but it's actually quite limited. So I think it's very, very important that we begin to recognize communities are a bit like football matches, where you've got 22 people who least need the exercise doing all of the hard work, and you've got 3,000 people who most need the exercise shouting at them, telling them what they should and shouldn't do, or else, just disengaged. I think the challenge really is finding ways that people can manageably, doably, and safely engage around their passions, around their skills, around their knowledge, and around their experience. So they feel like there's somebody. And that's why I'm a bit hesitant about some forms of social prescribing that I see, because I think the focus is too much around the need and the potential activity, and not enough around that person's need for reciprocal relationships. So a big part of where people don't join loneliness groups. I know most of the older people I'm working with are experiencing two things when they experience loneliness. One is social isolation, but the other is the sense of being useless. And they will say to me, I would rather continue to be socially isolated than to be a burden to anybody. But it's interesting that when you discover that they were a former librarian and that they're willing to read to local kids in their community, and you find a way of brokering that in where they feel useful rather than a lonely person joining a lonely group, suddenly the magic happens. So I think we really do need to shift the narrative away from you're needy and I'm going to get you an activity to you're needed. We can't do this without you. Then I think more people will show up on land, show up, grow up, clean up. They're the things we need more people to do, and connect up. So thanks, it's a great question, Nikki. I hope I at some level addressed that. Good. Let's go on to connection, and then we'll stop again and try and have some more interactions. Does that feel okay? Before we do, let's just check in the chat. Okay, all good. All righty. So one of the challenges, I think, is that, let's move this on a bit. One of the challenges, I think, is that we can discover what's going on within neighborhoods, but if we don't find a way of supporting the community to connect what's there, we'll end up really, I think, with just a nice list, a nice map of assets. So, you know, in a sense, my own feeling on it is to go back to Josephine's question around what could a hospital do if it was thinking about population health. In our work with Sing Health and Yishun Hospital in Singapore, where they are dealing with populations of several million people, their whole population health strategy as a hospital has been around supporting communities to discover and connect local assets as a starting point. So it's almost like a 3-lane swimming pool where they're recognizing for good population health, in the first lane, they need to support communities to do what communities are best placed to do through community organizing, volunteering, mutual support, good connections. But then in the second lane, there are things that people do need help with. We have different words for that: co-design, co-production. But the idea here is that the institutions, the hospitals in this case, are precipitating. So they're a support, they're on tap, not on top, as it were, but they're essentially extending community capacity. That could be mother and toddler groups. It could be book reading clubs. You know, there's a diversity around how we can think about health at the neighborhood level. And we're seeing really, really good evidence, you know, funded by many very significant progressive hospitals, that it doesn't just reduce demand, but it actually drives up better health outcomes and addresses a lot of health inequality. So, you know, I suppose that third lane is important to note, though, that even though there are things communities can do for themselves, mainly if we remove the barriers, and there's things they can do with a modest amount of help, there are also things communities do need done for them in terms of health intervention. And I think part of the challenge sometimes is we're not spending enough time saying, actually, it's not an either or. We need to get the sequence in a virtuous relationship. We're stuck very much, I believe, I work in about 36 countries around the world. I think we're largely in health and social care. We're stuck in the third lane, worrying about reforming our system, dealing with the crisis, trying to manage the institutional demand. And we're spending hardly any time. It's an afterthought around the first and second lane. So this is a real challenge, I think. I'm not proposing that this is simple. It's perhaps not technically hard to do. It's probably a matter of courage and disruption. So some of the implication of what I'm saying is I'm inviting you to disrupt the status quo. I'm inviting you to ask awkward questions. I'm inviting you to ask why it's always the same people from the same neighborhoods that are occupying your beds, you know? And so in that sense, I think when we talk about connecting the assets, I think we're talking about a shift away from the hospital doing a needs analysis to the hospital doing an asset inventory and beginning to show communities that they are health creators and not just health consumers. This is really important because think of the hospital or the primary care or you as a professional. If your whole narrative is, you tell me as a passive consumer what it is you need me to do to you or for you or with you, then we're not having the best conversation. And I don't think we're going to get to sustainable well-being. We might address sickness, but we're not going to get to well-being. So I think the well-being journey has to involve the person as an active producer of health and well-being. It's got to create the idea that they're in the driving seat of change and they're not on their own. This isn't about lifestyle change. This is about citizenship and being collectively held by a community and then supported by our institutions in a supplementary sense. It's the 3 lanes of the swimming pool. So for me, connection is individual and collective in terms of relational power. And thinking about health in that way means that we're recognizing that health is not a medical good, it's a social and it's a political right and good. I want to share a quick story. Because sometimes I think real life examples are much more useful than theory. So this is a story from Sardinia, from a village called Ulasse. And it was a village that really was quite problematic. Quite a lot of family feuds had divided this village, which essentially almost hugs the side of a Sardinian mountain, as you can see there in the slide. And the person that you see weaving thread in her fingers is a very famous Italian artist by the name of Maria Lei. And in 1979, Maria Lei was commissioned to do a piece of artwork. And this has become a really significant story in public health. But the artwork originally was to create a monument to the fallen dead of the First and Second World War. But Maria disagreed with the commission and instead began a process of community conversations, where over the period of a year, she spoke to everybody in the village about what mattered to them and what they cared about. But particularly, she wanted to know what they cared about enough to take action on. And the 2 things that were shared, routinely, regularly with her, one was people felt very disabled by the feuding, but didn't really know what to do about it. So there's that kind of sense of it. It's not dissimilar to what it feels like when you're living in a community where gang violence has become normalized. The real sense of not knowing what I can do to influence this. But the second thing was more unusual and less predictable. People kept telling Maria about a story. Nobody knows to this day whether the story is true or false, but it's a story about a little girl, a shepherd girl, who went up into the side of the mountain to bring some food to shepherds. And when she arrived to the place where the shepherds were, a storm descended, a very, very violent storm. And she was a young child. And as she looked into the eye of the storm, she saw a blue ribbon floating in the eye of the storm. And she became entranced and she ran straight into the eye of the storm. As the storm became heavier and more violent, the shepherds took shelter in a cave. And eventually this little girl caught the blue ribbon and returned to the cave to show the men, only to find that a landslide had claimed all of their lives. They were all dead. So she brought the blue ribbon back to the community and also the tragic story of the loss of life. And for some reason, this was the story that people told Maria when she invited them to tell her stories of significance about this community. So after a year of listening, she called the entire community together. There was about 1,000 homes in the community, and she told them what she had heard. And as they talked, she suggested, being an artist, that it might be really interesting to find a way of taking this metaphor, this story, and externalizing it, making it meaningful, making it real, in order to start a new dialogue. This was in 1981. And in September 8th, 1981, with 27 kilometers of sky blue ribbon, they tied every single house in that village together as a piece of performance art, and also, I would argue, as a piece of public health. Now, it was interesting, it was the night before they did this, there was a little bit of conflict, not unusual in this community. So a number of people said they didn't want to be involved. And this was problematic because the only way this would really work is if everybody was involved. So that was the nature of the proposition. So they sat down into the late hour talking, and 5 women particularly stepped forward as connectors and as peace builders in the neighborhood. And eventually a resolution was reached. They came up with what they called a tie code. So it worked like this. If you lived in a home where, you know, a son or a daughter married the son or a daughter of a neighbor, then you tied bread with a blue ribbon between your houses to symbolize this deep connection. But if you lived in a home where there was conflict and feuding with a neighbor, you tied knots between those houses, depending on how complex. It could be 12, it could be 2, you know, you decided. If you lived across some neighbors where things were straightforward, you can see this lady smiling. So she is just putting a very straightforward link between her house and her neighbor's house. And so that's what they did on September 8th of 1981. It's become a very, very famous story. And I think the reason it's famous is not just because it's sweet, because, to be honest, it's somewhat motherhood and apple pie, except for the fact that 40 years on, Ulas as a neighborhood, as a village, is peaceful, is prosperous. Its economic and its tourism-based future is phenomenally bright. And what's also interesting is that Sardinia is one of 5 blue zones around the world. So in terms of well-being outcomes at all of the social determinants of health levels, what you're seeing here is something really important, I think, about the value of connecting at the neighborhood level in order to create almost like the carrying capacity of the various interventions that we bring in. So my point here is this: the health and well-being outcomes of the people who lived in this community were disastrous prior to this intervention. So effectively, to Josephine's point, they were just basically falling in the river and being plucked out in the hospitals and being patched up and then sent back in to a context that was sickness creating. What Maria laid it with no health professional background at all, but I think what she did is exactly what we should be seeing more of in public health. I think I would challenge my friends in public health to get beyond behavior change, to get beyond behavioral economics, to get beyond lifestyle change, to get beyond smoking cessation, to get beyond obsession with obesity, and to really start doing this work. Because actually, if you did, I believe the outcomes would be just as good. In fact, we know from the work in the town of Frome in Somerset that doing the connecting work at the level that I'm describing, it does improve. Statistically, it improves health and well-being outcomes by 27%. So there's some really good science on this. Brigham University, the Canadian university, did a very influential study of 3 million, a sample group of 3 million people, where they found, echoing the work of Robert Putnam in 2000 in Bowling Alone, in 2015, they found that if somebody in the sample group joined a club, an association that they previously hadn't been a member of, in other words, if they were not a member of any association and then they joined, that they reduced the likelihood statistically of dying the next year by 50%. So if you have scientific questions about the power of connection and the power of community, maybe you know of medicine that can get better outcomes, but I certainly don't. So I want to stop there and again, just check in with you to see what's kind of alive for you as you listen to this conversation and this idea and the importance of not just discovering assets, but also connecting them fruitfully so people can move into a more health creating, economic creating future together. Now, let me stop sharing the slides, and perhaps if we could hear from some other people that we haven't heard from. So I suppose my open question is, what strikes you about what you've heard around connecting?
Good morning, everyone.
Good morning.
Hope everyone is doing well. I had a few thoughts during the presentation that came in, and I tried to kind of sum it down into one large question, right? So now, if you take into consideration that we're trying to build from the community to the institutions, instead of going from the institutions to the community, my issue is that we've come from an era of 2 years of isolation within our communities, right? Which has kind of made people more desensitized, not only to human interaction, physical interaction, and having this need to be within communication and contact with people, but also has desensitized people to death in that whole aspect, because we've experienced so many people dying in a short period of time. So now, how do we then bring about a change in people's mindsets? Because if you look at the society that we live in now, the fences around our houses are becoming longer. The distance between neighbors, the interaction between neighbors has reduced on a large scale. So now, if we are trying to connect a people, especially a community, it's no longer as easy as it was back then. Now people are more independent, more reliant on themselves, and mostly reliant on institution rather than your neighbor, because your neighbor essentially knows nothing about your issues and what you're going through, that type of thing.
That's a great question. So there's a couple of things that immediately strike me. First of all, I agree with you. I think there's some kind of appropriate intervention that's required in order to enable this discovery and connection. And I think a proportionate or an appropriate intervention is probably going to have to come from institutions. Ideally, institutions that are close to communities. So it may be faith-based, it may be cooperatives, though many of them sadly have also become undermined over time. But it can also be like in the city of Leeds, where in the UK, where there was a very strong recognition of what you're describing, that communities are becoming more and more atomized. And they've started to invest in employing community builders who work in the neighborhoods to address this issue, to support people and to journey with them, at, as I keep saying, the speed of trust. And different people will find different entry points. So there's no right or wrong way to enter into civic life. And there's no right or wrong pace. It takes time. What I like about the projects that I pretend, I like, there are millions, but I really like lifting up certain ones. So what I like about Leeds is that they recognize that in a neighborhood as a primary unit of change, that it won't just happen, that you actually do have to begin to invest in those relationships and in those connections. And one of the very cheap actual ways of doing that is employ some community builders who know how to build those relationships, but are not just doing it for the institution, they're doing it for the community. So they're facing out to the community. And I think that's something that used to happen years ago. I think you're absolutely right. And modern life and COVID have made that very, very difficult. So my feeling is it's going to be very hard to do modern public health unless we have boots on the ground and people who understand community development really, really well. But if we do that, the return will be significant. Sorry, I'm getting some. Is it possible for people to mute?
Keep doing. Hello, whoever's just joined and is known as iPhone, could you mute, please?
Thank you.
Thank you.
So I I agree with you. And that's why I believe in the importance of community builders or community animators, which is a paid role. And it needs to come out of mainstream budgets because people are not going to be able to find the money themselves, typically. And we need to start investing again in our communities. I believe what has happened is we've taken money and we've invested in individuals and we've invested in institutions and we have forgotten about the places that we're working in. Please.
So my concern with one of your comments is about the whole budget and mainstreaming of finances. The concern has become that COVID has put so many people in below the poverty line, and some people have lost their livelihoods. So chances of people taking corruption into hand with these kind of initiatives is really high. It's just one of the thoughts of how we can actually tackle that, because currently in the country that I'm in, corruption is very, very high. And it's really sad to see something beautiful go into ashes.
Yes, yeah, agreed. I'm actually working with one of your ministers in Cape Town, so I'm familiar with the South African context, and we have a number of projects. So I'm not talking abstractly when I say what I'm about to say. I think what I'm saying is that polarization, corruption tend to happen when people are disassociated from each other and isolated. When the work that I see, when the work is done at neighbor to neighbor level, and it's about how we can flourish forward fairly, how we can begin to build back things that, and I hate that term, build back better, but we can, begin to kind of use the assets that we have to secure the lives we want. I think that's a completely different conversation to the conversation that we so often hear. And I recognize, what came alive for me as you were talking is I remember conversations in Kibera in Nairobi, and again, a different context, I know, but around sexual health and around, some of the awful, horrendous myths that some young men had when they had AIDS and HIV around how to get rid of it. And it was the burial societies that influenced change. It was the associations that started to reshape and reform the way they thought about their behaviors. It wasn't the public health practitioners. It wasn't the NGOs. And largely what I saw was that the NGOs were engaged in some kind of tacit form of corruption as well, because they needed to prove that they were having impact. So I was seeing, public health facilities being put in sections of the community where nobody in the community wanted them. I was seeing very little real community development happening. And that's a challenge I've also laid to one of your ministers in Cape Town, saying, you keep talking about communities as if they're out there, some kind of alien force that can't be trusted, that, it's almost like that Freudian narrative of if we trust them, they'll just all go crazy. And actually our experience is quite the reverse, that people are waiting, that most people are good, that most people are generous, and actually that people will oversight each other. It's like the counter to safeguarding. Often people say to me, we'd love to do what you're talking about, but will people be safe? As if somehow being surrounded by a community is a safeguarding challenge. And I would say many of the reasons why people are abused is not because they're surrounded by people, but because they're isolated. So my challenge in political terms, and I laid this challenge to our friends in Catalonia yesterday as they introduced new policies to protect third sector organization, is please don't treat third sector organizations as a proxy for community. Because a lot of third sector organizations are in that money dynamic that you're talking about. There are 2 million NGOs, by the way, in the continent of Africa at the moment. How many of them are doing what we're talking about? I don't think too many. Anyway, I could go on at length about this, but I shouldn't. It's a wonderful set of questions. Thank you.
Sorry, Cormac, we're coming up to 10 minutes past 11, so I'm just wanting to.
Yeah, well, let's go to Mobilize, which is
keep
the last
you on track, if that's okay.
Yeah, no,
it's
that's
been fascinating. Thank you.
We're doing it together. So look, let's just cut to the chase. So first of all, really quickly, I'll say here, based on our social science, here are 7 functions that we think connected communities are essential for, that there is no government proxy for or no third sector. So enabling health, properly understood. Right? Health is not the monopoly of the doctor. And if it becomes the monopoly of the doctor, we risk burning Josephine out, which is not a good thing to do. Okay, so one of the great powers is to say, your health is in your hands, in the hands of your neighbors, in the hands of your local economy, in the hands of your environment. And my job is to support you to feel powerful within that, and then to do for you what you can't do for yourself or you can't do with your neighbors. And if we do that, we'll get in right relationship. And that's as much about security, you know, caring for the environment, our local economies, food production. We see what's happening in Ukraine currently. Food production in season is going to have to be seriously engaged with, and food sovereignty is going to become a huge, huge part of how we move forward and think about population health. We have essentially got food deserts in many of our neighborhoods now, and it's absolutely avoidable. And folks, the answer isn't food banks. I just want to emphasize that. That is not the answer. We need to think much more creatively about food sovereignty, much more creative ways of thinking about collectivizing and cooperativizing food. Raising our children, nobody wants our children raised in institutions. It sadly sometimes happens, but mostly we want to try to find community alternatives. And I think it's hard to talk about well-being without also talking about care. But I just want to speak up for the idea that care is the freely given gift of the heart, one person to another. It's not a service, right? And so much of how we talk about healthcare, Medicare, you know, well, Medicare don't care. Institutions don't care. People care. So we really need to get back to that. And, you know, anybody who thinks their institution cares about them should go to a retirement party and then watch how quickly the person who's retired is forgotten about in the institution. And you recognize that an institution is set up to ensure that you're replaceable. You know, when you step out of line and your supervisor says to you, don't think we can't replace you. All they're telling you is that an institution is not a community. They're not being mean, they're being real. But these functions are really important. I think that a lot of communities don't know that that's the work of community. I think that point that was made earlier on, you know, so I don't know your first names, Kunda, is it? Yeah, was making such a lovely point, I think, around the challenge. I think people have forgotten that there's work to do in the neighborhood, that there's work to do in communities. And I think we need to support them. So in a lot of ways, you know, we don't have time to get into all of the stories, but there's stories from all over the world. This is a wonderful story about an island community called Fogo Island, which has begun to resurrect their health and well-being from the ground up, using crafts and using the local experience of people. I love the fact that this started with a conversation. What do you love? Was one of the questions. What do you love about here? What do you love about Fogo Islands in Newfoundland, where I'm going next week? What do you miss? What are the things that we've lost? Their cod fisheries have been depleted pretty much over the last 30 years. So their economic base has been effectively destroyed. But they're resurrecting a sense of community from the dust up. It was like Maya Angelou often says, you know, and still like dust we rise. It was that kind of sense of anti-fragility, which is, I think, very beautiful. So I have to finish. As with everything, these things have to come to some form of conclusion. So the final few words is around mobilizing, and then I'll hand back to Jane. So I think what we're mobilizing is around that 3-lane swimming pool. We're trying to think about health and well-being in good sequential terms, because we recognize we can't know what a community needs until the community first knows what it has. So how can we start a different conversation? And we're doing that in countries all over the world. So we're not just abstractly talking about this, we're doing it with hospitals, with governments at different levels, and most particularly with communities. Final story, and I will finish on time, Jane. The final story is, I'd mentioned it, around Edmonton. So you've got this bizarre scenario where the province of Alberta, where the city of Edmonton is in Canada, was up to a number of years ago spending 50% of its tax take hospitalizing people, and particularly women over the age of 65. And, you know, when asked why, the answer was because we don't have a community alternative. People can't go home. And so we began the challenge of, well, that's the issue then. It's not about more hospital beds. It's about more hospitable communities. Isn't that right? You see that? So, and that takes some thinking, because most of us are trained to professionally defend our profession. So to see the problem through the lens of our profession. And what I'm offering you is a broader lens, right? Instead of seeing the koala hugging the burnt out forestry, I want you to see deforestation as the issue, and then try to address that, right? So that's what we're doing in Abundant Communities. Edmonton is about connecting every single person in every neighborhood. We're up to about 117 neighborhoods. What's really, really interesting here is what that does to the number of people who are actually accessing A&E at the weekends in that city, the number of people who call the police, the number of people who are not biomedically ill but go to the doctor. And all of these numbers have changed. And I do want to reassure those who quite rightly have questions about health inequality, that this isn't just a matter of reducing demand on services. And perhaps I'll close by saying that what this really is about is ensuring that people do not become institutionalized, but that instead we measure our success by the extent to which people are interdependent in natural, diverse communities with excellent, best of services, supplementing and supporting them to have a good life. And, you know, it's a simple narrative. I don't think there's anything too radical about it. The only thing that makes it radical is where we are right now. So the shift that I've been advocating for, again, is the shift away from a delivery model to a discovery model, a shift away from selling our content of health to really making contact and connections matter. So making it relational in terms of welfare. And then that final shift away from what's wrong to what's strong. So mobilizing the strengths of the community and then supplementing those strengths with our expertise, with our science, and with our programs and supports. I'll stop there and hand back to Jane. And thank you.
Oh, thank you. Thank you so much, Cormac. That was a really thought-provoking session. And I think